If you picture the length of a needle, when you aspirate, you're only aspirating one point. Welcome to the Aesthetics Mastery Show. I'm Dr. Tim Pierce.
Hi, I'm Miranda Pierce.
And today we're talking about a very important concept that I think underpins some of the attitudes that make for really safe injectors. We're going to take this concept and we're going to apply it to products and aspirating and injecting different parts of the face. So make sure that you understand this important way of understanding risk and how it can make you a safe injector. So let's dive in.
So what got you thinking about this?
Oh, before I answer that question, don't forget to give us a like if you have some faith that you're going to learn something today, and it'll also help YouTube deliver our videos to you next time you log in. So once again, there is this continuing debate around different topics in our sector, and obviously being our sector, there's tons of emotion behind it, but actually it's often quite small things, but important things, because ultimately these things affect patients. So I'm personally a very big fan of debate. I think so much information comes from when people meet and disagree about something, not necessarily for the people involved, because they often polarize each other and stick with what they've always believed, but there's certainly something in it for the audience who get to see how these ideas clash together and make a judgment about what's the right way to understand things. So there was a debate recently once again around aspirating, like should you aspirate? And various people come and put their points of view across. And I noticed that the biggest difference between, and sometimes uniting the two people, was the idea to think probabilistically versus in a black and white manner. So thinking probabilistically is very different from either or way of understanding the world. So either aspirating makes you safe or it doesn't make you safe. Either we do allergy tests on everyone or we never do allergy tests on people. And these are kind of, this black and white way of looking at things is what leads to most disagreements. Because actually, I've learned long ago, long before I got into aesthetics, that often whatever your position, the truth is more complex. And I'm a big fan of creating that space to have disagreement and nuance so that we can effectively make progress. Because I think sometimes the black and white way of looking at the world causes a delay in understanding, because people get too pinned to a black and white scenario, which is necessarily always incorrect, because the world is much more complicated than we can figure out, especially in aesthetics, with the tiny studies that we do. The evidence is hard to scrape together. So this idea of thinking probabilistically might help people see each other's points of view. And I think certainly over time, it makes sense to me that it will help people become safer.
So make it real for us with the example of aspirating.
So the aspirating debate centers around, it's possible that when you're aspirating, if you ever do get a positive, it's probably just a hematoma. I've heard people say that. And they say that on the basis that there's trauma caused by the injection, and even the aspirating itself can cause trauma, and then you get a flashback, and that's the only reason that you've got a flashback. So that's essentially a black and white argument, which is saying that all flashbacks are essentially a waste of time. They're a red herring, and they haven't told you anything. On the other hand, there's also the argument that aspirating doesn't actually work because, well, effectively a lot of fillers don't actually allow product back up the syringe. So the probabilistic way of thinking about this is there space for this technique to chip away at the risk, even if it doesn't bring it down to zero? Because some people do teach aspirating as if it's 100% effective, and it's definitely not. Like, you definitely cannot tell with one simple aspiration of the syringe exactly where you are in the face. Like, you may be right in the middle of a big artery, but is there a chance that aspiration will give you some information which might some of the time give you the ability not to occlude a vessel? To try and make this more real, if you picture the length of a needle, when you aspirate, you're only aspirating one point. So if you think about the area that you might be in terms of the artery, it could only be 1% of that needle that you're actually measuring. It is 1% of the needle that's in the length of the skin that you're actually detecting whether you're in a blood vessel or not. So this is one way of saying, how absolute is it? Well, it's not. It's definitely not scanning the whole face for the position of the arteries. You're actually only scanning one point. So does that mean you never aspirate? Well, what about the fact that in those potential areas when you have aspirated, there's still a chance that you might get blood back. So there's still a good reason to test that area, because that's also where your filler is going to go, at least the first part of your filler. Now, so it's a very important area to screen. So it's that kind of nuanced discussion around, yes, it's not perfect, but it's still useful.
I guess the people who don't like aspirating would say that probabilistically maybe it helps, but is that probability, does it outweigh the risk of doing an additional intervention?
So the additional, the trauma of aspirating,
Yeah.
for example. Yeah, I actually haven't seen that come up. Usually it's more of a discussion around, but that's a very good way of thinking about it. But usually it's a discussion more around whether it works or not.
Yeah.
And
why do they say it doesn't work?
so one of the reasons it doesn't work is if your filler's too thick. So we did an experiment on this. This is one of the reasons why I did the experiment, which is this idea that when you're injecting, if you've primed the needle, it no longer is sensitive to any aspirating, or if it is, you've got to aspirate for the very minimum 10 seconds, which is actually a very long time. If you're doing a big procedure, your injection takes 1 second, your aspirating takes 10 seconds. So it lengthens the time of your procedure enormously if you do that for every injection. So people don't like doing it. But all of those are they're not probabilistic in the way that they're phrasing it. They're saying there's no point unless this. And actually, when we tested it with the fillers, we got a range of different results. So many of the fillers, very reassuringly, aspirate within a second, so very quickly. And this was in my own forearm. We'll post a link in the video so that you can see that experiment or get the free download, where we have the timings of different fillers. It revealed to me is that every filler has a different probability of aspirating in a different situation. And then if you change the needle, that's another different probability. And of course, different areas of the face have different arteries, different anatomy. And I don't just mean according to what the textbook says. I mean, there's differences between individuals. We just don't match the textbook. Huge variation. I know there's something like 40 different variations of the facial artery, but those are simplified variations. The reality is there's almost an infinite variation of the facial artery because little wiggles here and there are not documented as differences, but they are. So we all have different anatomy, and that means you've got to approach the whole thing as in, is there a way I can make a tiny incremental difference in the risk of this procedure, which makes sense to me, and apply that as one of many different steps. So it's not this idea that aspirating makes you safe and not aspirating makes you unsafe. It's that it's one of many different barriers you put in the way of a potential vascular occlusion, not a single one-step saves you from all the problems, because obviously that's just not how it works.
So we might choose aspirating as one probabilistic way to improve safety. What other choices can we make to gently improve our probability of not causing a problem?
So actually every angle, every filler choice, even standing different sides of the bed probably makes a difference in the total risk, because but this only makes sense when you don't think about the individual procedure, but you think about the stack of all the procedures that come out of your clinic over 20 or 30 years. Because really, I sometimes have this image of imagine a moving anatomy. So you have someone on your bed, but actually her anatomy might change every second for the whole time you're with her, because that's what it's like when you change patients. Every patient has a different anatomy. So what you're actually injecting is your understanding of the average face, but almost like probabilistically. So if you look at the position of the artery, in probabilistic terms, it isn't running in a snake down the side of your face or running in a straight line on either side of your nose. It's actually covering a much broader area. And then the probability of it being there decreases as you move away from the highest place of probability. But it never gets to zero. I mean, that's an interesting way of saying it. It never gets to zero, the chance of your facial artery running up the middle of your face. Except that you'd see it going through your lip. But say the position of where your artery is meant to enter, that there's variation enough that from a probabilistic point of view, if there were an infinite number of patients, you could find it anywhere. So you can't rely on the anatomy. I think that's what Dr. Subio was talking about in one of his lives. He says that the anatomy doesn't matter. I think the central point there is it's so much variation that you can't rely on what you know about anatomically. But paradoxically, and I'm sure you would have made this kind of point as well, you must take what you know about anatomy and apply it, because that decreases the probability. But if you ever see two clinicians arguing about the position of the facial artery, they're probably thinking non-probabilistically. It's black and white. It's either here or it's not. And the actual probabilistic way of looking at it is that it's almost everywhere. It could be anywhere. And so we need to take a bet where we think it is, and then we need to act as if it's everywhere. And that's a very different way of thinking. And I know people like black and white things because it gives you certainty, but it's just no way to go through this. You'll find yourself disagreeing with people all the time.
Yeah. I mean, I think the problem is less about the disagreement with other colleagues. It's about just, I'm already feeling a little bit overwhelmed. Like, oh my God, there's so many potential problems and I have to think in 3D. So I would like the idea of I would like to decide whether or not to aspirate and then make the decision and that's it. Just like putting your seatbelt on. You just decide and it's done and you don't worry about it and you just do it.
Well, I'm arguing in favor of aspirating, even though it doesn't give you 100% protection.
Yeah.
And maybe even if it only gave you 1% chance of reducing the chance of vascular occlusion, there's still an argument to do it. And this is where it gets tricky, is that I saw one Canadian study where they said it only worked 30% of the time. And I've seen people using that as a reason not to aspirate. Now, in my mind, I'll have that 30% chance, please.
Yeah,
I'll put it on amongst all the other things I'm doing.
Yeah.
And I might even look into that and figure out what affects the probability of a positive aspiration. So one of the things, as we have already discussed, we discovered in our example was that different fillers have different probabilities of giving you a positive. And that's only one of the variables, because the artery itself will give you a different probability as well, and each individual patient and maybe the thickness of their blood, all these things contribute to the probability. But if I can have 5%, I'll have it. And the discussion about the trauma, well, maybe there's a way it can reduce the chance of trauma being the cause as well.
By injecting smoothly and
and practicing your technique, because aspirating is, I have this inkling, and I'm open to disagreement on this because there is obviously a lot of science in this area as well, but it is tempting not to like aspirating, because when you train people like we do, if you train someone on their first day of injecting, trying to train them to aspirate at the same time is messy. Like they're clumsy, they haven't got the dexterity, it seems to elongate the day forever. That's why we use mannequins to start with. But I've always thought, get over that hurdle when it's messy and it might be a bit more traumatic, because as soon as you've got your technique right, it's actually not traumatic. It's smooth, it's effective. You can see injectors on Instagram these days aspirating seamlessly, you almost don't notice. And so that the argument for trauma goes down when you're good at doing the actual technique. And that's easily attainable. Everyone will do it. To be honest, even if you don't think about it, your brain automatically gets better and better at it. So a year of aspirating and you're smooth by the end of it. But if you've never done it, then it looks clunky.
We did a show on Tim's tips for smooth injecting, etc. So I'll link that below.
Yeah.
So tell me about filler choice.
So this is to illustrate this concept further. If you think about the question I often get asked is, which is the safest filler? Now, there is no solid answer to that when you think probabilistically, because you could look at it as in which is the easiest to dissolve. That's one parameter. And you may make the argument that a thicker filler is harder to dissolve. So if you have a complication, it's going to be harder to resolve that complication. But there are other factors as well that affect the total risk of the filler. So when I looked into blindness and looked at the case studies of people who had blindness after dermal filler, I noticed there seemed to be quite a few low viscosity products. In fact, some of the first examples of blindness from injections came from very low viscosity things, such as the steroid injection. And this is an indication, I think, that one of the risks might be that a product can flow easily through the vasculature. So if you particularly with the anastomoses that we have in the forehead. So you have an anastomoses between the superficial temple artery and the supratrochlear artery. And if you're injecting in the temple, one of the cases in the UK was a temple injection, if that's a very low viscosity product, it might flow very easily into the orbit, whereas a nice thick product would probably not flow so easily through the vessel. And this is just the laws of, this is Pucelli's law in terms of viscosity. If you're injecting a thick product through a thin tube, it's much harder than a thin product through a thin tube.
So if you were injecting temples, which filler would you choose based on the probabilistic risk?
So I mean, it makes sense to use a thicker product for that one particular risk. Now, you may still cause a vascular occlusion, and this is where people also get confused, is you can't only think about the frequency of the problem. You've also got to think about the severity of the problem. And we'll touch on this if we talk about needles and cannula, because the frequency of the problem may go down if you use a thin product that aspirates more effectively. So you might actually detect some of the times you're in a vessel if you only used a very thin product. So you're actually decreasing the number of vascular occlusions by using a thin product versus a thick product in that occasion. But unfortunately, if you're using a thin product and it doesn't aspirate, you may inject much deeper into the vasculature, and then you cause a much more severe problem. And that is actually true in many different cases. I think there are a number of different examples of where you alter frequency but increase severity. I think it might be true with cannulas as well, because if you look at the data, particularly with blindness, about people who had severe injuries from injectables, there's a disproportionate representation, I think, of cannulas. And it's something, I think, to do with the technique that most people use, particularly if you're running parallel with the dorsal nasal artery, doing non-surgical rhinoplasty, which is common, that perhaps it is less likely with each insertion that you will find yourself in a vessel with a cannula, because they have a rounded tip, and the theory is they push vessels out the way, and they do, I believe they do that. But if you do get into a little V-shaped connection where the only way is to go through the vessel and you push through, 25 gauge cannula, you absolutely can occlude a vessel. But then you stay in the vessel for much longer. So that's the downside with cannulas, which is that you don't tend to move them, particularly in the nose, in many different directions. So you're in the same place. You can aspirate. Most people don't, because they don't believe it works. Test it. It actually does work in some products some of the time. So you might get a positive. And when you inject, you're staying in that plane for such a long period of time that you basically put a lot more product into that area. So 0.1 mils would be a fairly normal amount to inject for a rhinoplasty, and that's easily enough to completely occlude the supratrochlear artery all the way into the orbit and cause blindness. So it's less likely to cause a vascular occlusion, but if you do, it's going to be a bigger vascular occlusion, and that's probably the trade-off with cannulas.
What about people choosing the BD syringes for lip filler? Does that reduce the risk?
So the BD syringes we tested, the benefit of the BD syringe is that they've got a shorter needle, so that decreases resistance when you aspirate. And the ones we tested all aspirated at least as well as what came with the manufacturer's syringe, or better. So that's positive. But there are other risks. So you could think, you're actually really having to trade this off against, some people say, are they less clean because you're messing about with product and squirting some into a different syringe. And there's no data on that, but there is an additional step. And I would say I think it's possible to do that procedure very cleanly and not increase the rate of contaminants. But think about millions of practitioners all doing that. With the additional step, absolutely, the probability is at some point there'll be some contamination. So the probabilistic way of thinking just leads you to entertain those ideas. It isn't black and white. There's an extra step probably over the many procedures that are carried out. Some are more likely to involve an infection than if you didn't have that step.
How do we apply this approach to which injection technique we choose?
The way I think about injection technique is you should be able to correlate the probability of injury going up or down when you understand anatomy really well, depending on everything that you're injecting. So as you go deeper, are you getting further away from the vessels or closer to the vessel? If you're changing your angle and you think about the probability of keeping on going in that direction, are you going closer to vessels or further to vessels? And this, when you think about it clearly enough and for enough time, it starts to guide your decision making. So if you think about, for example, a nasolabial fold injection, we've done a video on this, injecting this area. It's very close to a number of vessels, but you can imagine how changing your angle of position will alter your proximity to those vessels. Now, it's not to say that you'll alter them by changing it by 1 degree that you're going to inject the vessel, but you are getting closer to where the vessel tends to be, and so the probability goes up. But similarly in the other direction, there's a point where the risk is averaged out, and then there's a point where you're starting to get closer to the other vessel. So the superior labial artery might be the other vessel that you think about. You've also got the infraorbital artery and the facial artery. So when you're changing your angle of injection, are you thinking about your proximity to those vessels and trying to find a position with your understanding of the anatomy that makes sense in terms of how you inject? It sounds like a lot of work, and it is something I do think you do have to think quite a lot. But once you've done it, it starts to guide you intuitively, because as long as you've got a good mental model of the face and where the average position of these arteries are, it actually feels better in the long run. Because I think what clinicians pick up sometimes is there's a lack of certainty when they're injecting. And although we'll never get to zero, just thinking about balancing the different risks will be helpful. One of the things I also always say to trainees when I'm with them is try and learn the face in such a way so that as you move your needle in different angles and positions, you know what the outcome of injecting there is going to be. So as in what you're incrementally getting towards. So if you're injecting toxin around the eyes, for example, if you're injecting very superficial, the outcome may be that you get less effect from your toxin, but your bruising risk will be less. If you go a little bit deeper, what's going to happen there? You're going to be touching the surface of the muscle. That might be closer to causing a bruise, very near the surface, so you're going to be more effective. That's probably a good place to put it. What happens if you keep going? You go through the muscle. So underneath the muscle, the fat pad, you're now getting close to the origin of zygomaticus major, and you now know at that point you may get away with it, but at the same time you've got a higher risk of affecting zygomaticus major and causing an asymmetrical smile. All the way in, you might touch the bone. What's that going to do? Well, you're going to be miles from orbicularis oculi, probably not going to decrease the smile lines. You're very close to zygomaticus major, and therefore you're going to waste your product or cause a side effect. So that way of trying to weigh up at each point what you're likely to get in terms of probabilities, in terms of outcomes, is a very good way of understanding anatomy in the face. And you can actually do that with everything. So nasolabial fold injection, if you're too superficial, you're going to see the filler. If you're too deep, but at the wrong angle, you might be close to a vessel. But it's that way of asking yourself at each position, what's the potential difference between the outcome here compared with an outcome in a different place? And it's obviously a lot of work, but you only need to do one injection at a time. And actually, Roger Killer said this to me once, and it really sunk in, which is, if you think about it, for one injection, there's not that much information to know. And he's right, because there's more than people think, but at the same time, there isn't an infinite amount of information. There's a certain amount of anatomy, and then there's your relationship to that anatomy. And once you know that, you can become very confident injecting that area. And you can tweak it when you learn something new, but it's a really clear... It's a way of shrinking down the volume of stuff you might feel you need to know. Is just choose one injection and know it well.
I think you said to us in the past that you get very in flow and focused in the moment before you inject. You're just thinking about that and nothing else in the world.
Well, I'll share with you the difference between when I first started and now in terms of my what's going on in my mind. When I first started injecting, I was replicating what my first trainer taught me. I was thinking about what they did and trying to reproduce it. And my brain was actually quite quiet. It was more I felt the sense that my hands were doing stuff, but it wasn't really a lot going on in my mind. And now it is the complete opposite. Now I hardly think about my hand. I'm constantly thinking about the anatomy and the position and the variable and watching the patient. My brain is extremely busy now, but it's a nice feeling because I'm in an arena that I now know well enough to feel confident, have a degree of respect and in terms of safety, so I'm never completely relaxed. But that's actually one of the best places to be when you're on the edge of order and chaos almost, and you're delicately guiding each procedure to get an aesthetic result while also being safe. It's actually one of my favorite things to do. Put the music on, thinking heavily, lose myself for an hour and a half, and then afterwards it's like, where did the time go?
Yeah, that's flow, isn't it?
Yeah. But it's busy. If you're not weighing up these different parameters while you're injecting yet, then start to think about it. Start to think, instead of replicating the technique, how do I improve this individual injection to minimize risk, as if it was the injection I had to give everyone I ever meet from now until the end of time, because that's kind of what you're committing to anyway. So chip away at the risk. Think about those tiny differences that over a career will make a difference. And it's more entertaining for you, it's more fun, it's more intellectually stimulating, and it will ultimately be safer as well.
So it's a micro focus, but with a macro result.
Yeah, that's a good way of talking about it. So you're very much in the here and now with how you're injecting and applying all your information, but you're doing it as if this is going to be carried out for the rest of your career.
It's a bit like with sun cream. I always think that about sun cream. Living in the northwest of England, wearing sun cream seems a bit mad. But actually, I'm just putting my seatbelt on every day and just committing to the fact that is going to help me have fewer wrinkles and less sun cancer.
So yeah, actually, the seatbelt is quite a good example of how people do accept things that are based on probability and not absolutes in normal life, but then we don't always do that in everything we do. In fact, a lot of as we talked about, a lot of the debates you see on anything, like in COVID, do masks prevent the infection or not? They don't 100%, but they chip away at the risk. So that's what we're looking for. And seatbelts are one of my favorite examples because most times, we drive to the corner shop. Our kids' school is a mile away from where we are. And the chances of us needing that seatbelt are effectively zero. The chance even of being pulled over by the police is effectively 0 per trip. But if you multiply that behavior out over a lifetime, the chance of you needing a seatbelt, I've certainly needed a seatbelt at least once, that's where you get the benefit. So you have to put the seatbelt on every day in order for it to save you once in a lifetime. And that's kind of the same, I think, with aspirating and a lot of the ways that we analyze risk. And yes, it's usually pointless. And guess what? Some people are probably killed by their seatbelts. There are examples of where people can't get out of cars, or, there are all sorts of ways that it could make things worse. But we know that the net effect is good. We do know that now. I don't think we knew when we first started. There wouldn't have been any data. And this is what I think a lot of the aspirating argument centers around. Is it's extremely hard to get the data, particularly with aspirating, because there's so many nuances between injectors. The thing we're looking for, an occlusion, is actually a very rare thing anyway. So you're going to have to do a huge study to find, a handful of occlusions, and then compare it with another huge study where there were a different number. The power of that study would need to be enormous. So I don't think we'll ever get the final answer, a double-blinded study of people who aspirate who use exactly the same technique on people with the same anatomy. It's not going to happen. So I don't think we'll ever have 100% certainty in that, but we can work from first principles. And that's really the point of, to use the seatbelt analogy, if people are not flying through the windscreen, that might be a good thing. And maybe we should keep them in the car. Similarly, if you can get blood back in your syringe, some of the time, that probably has come from an artery. Now, not all the time, and there are lots of other things, and some of the time you'll be in an artery and you won't get anything back. But does it overall make sense that bit of information on those days could be useful? And for me, it's cut and dry. Of course, that information could be useful. And I'm not saying it's 100% useful, though. That's the key. It's just that it helps. It's one more data point to make a decision with.
But we're talking sort of about probabilities and stuff. But I tell you what makes it really, really real for a human being is when you see on the forums clinicians doing an aspiration, getting a flashback for the first time, and then they put the picture up on the forum and they're shaking and they're kind of nervous but also happy because they're like, yeah, thank God that could have been really, really bad. And it's the same with the car. When you are in a bit of a bumper bashing or something and it saves you the seatbelt, you think, God, thank God.
Yeah. Bicycle helmet's another example. There are lots of occasions where you only appreciate it when you've gone through it. The only thing with aspirating is it sometimes scares clinicians. I always think you should be reassured. It's a signal that you've got something back.
They're usually proud, I find, on the groups.
Yeah.
Scared but proud.
Yeah. It's reassurance that it does work clinically, because obviously the theory makes perfect sense, but it's nice to have that reassurance that it actually works in real life, at least some of the time. So I hope you've understood that today, that next time you see people arguing about is aspirating worth doing or not, that they're actually both right, but in different scenarios. And if you can become the clinician who understands the gray area and uses incremental steps in your injection procedure to make you safer, then I believe over a lifetime that can only be a good thing for you and your patients. But you do have to think differently. There is no right and wrong answer. There are just little things we can do that chip away the risk. And there are many of them. So you might have some you're already doing yourself. In fact, drop them in the comments. I quite like this practice, for example, of compressing nearby arteries when you're injecting, just in case you're in a blood vessel. There's less way that it'll flow deeper into that vessel. So there's no evidence behind that. Makes sense, though. Maybe it chips away at the probability. Why not do it? So I hope that was interesting to you. Make sure you like and subscribe, and there will be a little link below to the aspirating experiment that I did, and hopefully you'll find that interesting.
Tim had his brachial vein injected with we aspirated with different fillers. It's a very exciting experiment. If you want the download, a link will be below.
I was pretty brave most of the time.